Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind Podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. The Emergency Mind Podcast is brought to you by the folks at the Mission Critical Team Institute. If you want to find out more about what we're doing, you can find us at missioncti.com. My guest this episode is Thomas Preston. Now, Thomas is a leader and an innovator in cardiopulmonary care with over 30 years of expertise spanning respiratory therapy, perfusion, and extracorporeal life support, which is what we're going to get into today. He served in leadership and academic roles at Nationwide Children's Hospital and The Ohio State University, and he holds a Master of Science in Cardiovascular Perfusion from the Medical University of South Carolina, is how you say that state. He's also the executive vice president for Integration Health, which is actually how our paths crossed. And we met at the ELSO meeting and had just really like an interesting series of conversations. Sorry, I should say I met his team at the ELSO meeting. And then we had a really interesting series of conversations about how ECMO teams work. And man, it's just such a rich thing in there. And I'm so excited to have you on the podcast. Thanks for coming.
Yeah, thanks for having me. This is my passion. So the opportunity to get out and talk to you and more people about it is all you could ask for. So I'm very happy to be here and thanks for the opportunity.
So cool. We're probably not going to dive like ultra deep into the science and medicine of ECMO at the moment, but we're going to definitely dive into the team structure of it. So maybe that's a good place to start. Can you talk us through, and actually I'm going to say this, I don't even know if this is an answerable question, but what an average ECMO team looks like? And I get the feeling that there might be more than one answer to that question.
Yeah, that is the proverbial what looks right. And it looks different everywhere. And the team dynamics are so important for what we do and how to respond to situations. At academic institutions, you have the traditional cadre of attendings, fellows, residents who have been exposed to extracorporeal membrane oxygenation since infancy, right? The moment they walked in the door, they're seeing ECMO patients. Their involvement escalates with their career progression. They have this team of people at the bedside that everybody understands what everybody's role is. You have ECMO specialists that are monitoring patients. You have ECMO primers or perfusionists that get circuits ready or bring a backup circuit in case of emergencies. And you have attendings, residents, and fellows that understand the impact if a component fails or patient failure in differential diagnoses to get to what the true mechanism of failure is. And everybody comes to a very concise resolution of how to fix the problem. When you go into more rural settings or hospitals that are just getting into ECMO, you may or may not have a physician staff that's experienced in ECMO. You may have a nursing staff that has no experience with ECMO. You may have perfusionists on call, not available to the hospital. So you may have, in what we specialize in, is staffing these institutions that are starting up programs where one person in the building may be the only ECMO knowledge. And then during crises, how do you get that person to relay information to the decision makers and resolve a problem in very short order? So it's very different, those two settings, and the role that you play as the ECMO specialist or the primary perfusionist in those two areas, wildly different. And of course, then there's the normal differences between peds and adults that I don't want to jump into.
Sure. Let's lay a little foundation around this and then dive back into team structure. If you're listening to the podcast and you're in medicine, you've probably intersected with ECMO to some degree. It's becoming more and more prevalent these days across a variety of institutions and indications. But if you're listening from, say, the military side or the oil and gas side or any of our other folks who listen to this, might not be something you're familiar with. So loosely speaking, and please correct anything I say that's wrong from my simplistic ER doctor mindset about this, but basically we're talking about a heart lung or just a lung, but usually a heart lung bypass machine, right? So you have a human being who has some really bad problem in either their heart or lungs or both, and you've put them on this machine that takes some of what is essentially the work that your heart or your lungs does and offshoots it to this machine. Basically, this isn't usually how we describe it, but you've created a bit of a cyborg, right? You have a human being that has their own ability to do heart and lung stuff, coupled with a machine that has the ability to do the heart and lung stuff. And what's interesting about that is that you get into problem sets where either one or both of these components. So you have the person, the machine, and then the connections. And either one or all of these components can suffer a catastrophic failure. And so to solve that and to keep the system working really well requires a bunch of specialized knowledge that isn't necessarily taught in the normal sort of medical pathway. Right. So before we keep going, what did I get wrong about that? What needs to be tweaked from that sort of structure?
That was a wonderful description of it. And the two working harmoniously, there's nothing better. A
Awesome.
failure on either side leads to catastrophe.
Catastrophe, and in this case, by catastrophe, we usually mean, if not quite instant death, then like nearly instant death. So
That's
there's
exactly
not a lot of room in here for the time frames are exceedingly compressed, and the supply demand mismatch is problem is very high. You really need this system to be working harmoniously together. So, with that as a baseline, can you define for folks what a perfusionist is?
a perfusionist is the person that runs the heart-lung bypass machine traditionally in the operating room while the patient's heart is stopped and worked on either externally or both externally and internally. If they're putting a new valve in somebody, they would be on this temporary heart-lung machine where blood would be perfused through the body from the machine. Oxygen and is added to the blood as it comes through the machine and through the oxygenator. Carbon dioxide is removed. And while the patient is lying on the table with their heart stopped, the normal perfusion and oxygen breathing is happening through the machine, which the perfusionist is maintaining running throughout that temporary period in the operating room for heart surgery, or in the intensive care unit or in the emergency department. That machine is supporting heart and lungs, like you were indicating, due to severe illness or trauma or both for prolonged periods of time, sometimes weeks or months, versus the operating room where it's hours.
So you have in here a couple of parts. If we just abstract this out into sort of like systems theory for a second, you have a system that has to work together across multiple components. And at any one point in time, the amount of work that either half of the system is carrying can vary, right? So you can have a system where the human's doing most of the work and the machine is supporting them, or the machine is doing most or all of the work and the human is doing what they can as they heal. So there's a layer in here where you have a dynamic balance. That balance can change, but it has to work at all times. And everybody working with this patient, this cyborg, just because it's a fun word to say, right? Like they have to understand and share the same mental model of where the work is on the system at that moment. And then separate from that, you have a system where if anything gets out of sync or any component fails, the whole system might easily tip into catastrophe. That's a very sort of metastable thing. And we really rely on the perfusionists to come in and help. Actually, I don't want to finish that sentence for you. What do we rely on the perfusionists for? What's the role in this sort of meta team?
And the perfusionist, or sometimes the ECMO specialist, depending on the institution, is reliable for keeping everybody in check with what the machine's doing versus what the patient's doing. What's the balance between those two? And then we always fight this underlying desire for the blood to clot because it's being exposed to foreign surfaces and large foreign surfaces. And we try to ride this very fine line between hemostasis and bleeding everywhere. If the blood is clotting, we suffer loss of our ability to add oxygen and pump the blood around. If the patient's blood is too thin, a lot of people look for the oil and gas folks. We use blood thinners. If it's too thin, then we have bleeding that's uncontrollable from internal organs or externally through incisions we've made or lines that we've placed during the case. And then being able to replace that system in case of failure, replace components in case of failure or degradation of abilities. The perfusionist is the person that should be monitoring that, keeping track of it, ECMO specialist, and letting you know before you get to the catastrophic failure. So we always want to be looking at flows, pressures, interaction, ability to produce high oxygen concentrations, remove CO2, and be prepared for things that are going to lead to any one of those components failing. Unfortunately, the machine can be working perfectly and the patient can have new and unexpected problems, or cardiac effusion or tension pneumothorax or abdominal compartment syndrome that take away our ability to support them with ECMO due to cannula displacement or inability to get blood back to a certain portion of the body, unrelated to the machine, but the machine will stop. We need to fix the patient in those cases, not the machine. And we have other situations where the patient is unchanged and the machine fails. Either how many times have you had to reset your iPhone because there was a software glitch? We have machines that have software glitches. So we have software glitches that we have to be able to troubleshoot. And then we have true failure where you're driving down the road and your car engine quits working. It's not an electrical problem, but your car's still not working. We have those same problems where we can have console failures, drive failures, patient failures. And no matter what the failure is, your time to resolution depends on where your patient's at in that harmony of, are they doing the work or is the machine doing the work? Are they doing most of the work themselves or the machine doing most of the work for them? If they're in the latter stage where the machine's doing most of the work and the patient really has no ability to exchange gas or their heart's failing and they have no ability to pump blood around, if the machine fails, we have to run a code. We have to hope that during that code, we have some ability of the native lungs to exchange gas, or we have to hope that the heart can produce enough hemodynamic stability to perfuse organs that we need perfused while we fix the machine. And what ECMO brings into this from a complicating standpoint is there's very little in the ICU that fails that we can't take over for. If the ventilator quits, we manually ventilate the patient and we can get the respiratory therapist, the nurse, the resident, the fellow, the attending. Everybody knows how to run the ambu bag to maintain ventilation. Maybe not with the right pressure or the right volume, but they can exchange gas. Everybody in the hospital knows how to do CPR and we can do compressions. But ultimately, when you're on ECMO and you have an ECMO failure, the only resolution is to get the ECMO pump working again. So you have this event where you have to save the patient and support the patient. You have to fix the device, the mechanical part of the cyborg, and you may only have one person in the building that can troubleshoot the device and explain to whoever's leading the event what the solution is. The solution could be, we need a brand new machine. And if we're working under the premise that we have 300 seconds for an anoxic event, quickly making that decision, getting the new machine in the building, in the room, set up, ready to go, air free, has to be made early enough in that problem to get it changed out. Oftentimes when we're on ECMO, the patient may have a tidal volume of 25 cc's. It doesn't matter who's running the ambu bag. For the 25 cc tidal volume, you're not exchanging gas. So no matter how much you bag and how many compressions you do and how good your compressions are, if you can't get the machine fixed to add oxygen back into that patient's vascular side, you won't save them. So the best run code, the person who's the best at doing all of those things in the room will not matter if the person that's in charge of the device can't relay the problem, understand the problem, and fix them. And then in the hospital setting where there's one person, it becomes very important for them to share the problem, share the solution, and enact the plan while still supporting the patient as best that can be done while that's going on. So it becomes a very, very stressful situation. Everybody in the room is stressed out. And part of that stress is induced because they don't understand the problem. We all know the problem with the patient, but we don't understand the problem with the machine. And if the person that's responsible for the machine isn't able to quickly, not educate's a bad word, but quickly share the problem and share what they believe the solution is in a manner that people get on board with quickly, your outcome is almost assured. Very weird, because we think about ventilator failure, we think about the CRRT machine fails, we want it fixed, but the time to resolution is much exaggerated. If your patient is dependent on ECMO and it fails, your time to resolution, that is a very short clock, very stressful to all parties involved.
Thank you for laying it out like that. I think there's a couple features that are really poignant, right? One is that if you ignore ECMO for a second, you have a group of highly trained specialists who have worked their whole life to get to that job, who are proud of their skills and capable. And you've introduced a problem set that they basically cannot solve. And if you've ever been in one of those moments, there's a bunch of stuff that happens where you realize like very quickly the limits of your technique and the limits of your ability to solve certain problems. And that phrase that you said, no amount of CPR, doesn't matter how good the code is run, it doesn't matter how smart the team is or what medicines they bring to bear, this isn't a solvable problem from that standpoint. And if you've been in one of those rooms where you have this dawning realization that this might be an unsolvable problem for this human being, you realize how quickly you run out of options for them, one, but also two, how that affects the team and everybody that's in that space to try to work on a problem to which they do not have the tools to solve it. There's also a sense here of a dyad that we're building. And this is a very much an oversimplification, but I think this model is going to be useful. So bear with me for a second. But in some sense, you have this dyad. And on one side of it is the medical team who's managing the human being and doing all of the stuff. And on the other side of it is the perfusionist who's managing the machine. And now there's a lot of reasons why that metaphor is not true, right? There's a lot of integration that happens, right? I think that's partly why you guys are named that, right? But there's a lot of like synergy that happens in there and a lot of stuff that makes these two things being on the same side of the problem, looking at it together. But from some extent, we can say, hey, look, there's the people managing the person and the perfusionist managing the machine. And I think it's probably useful to inhabit both of those points of view and think about it from their perspective and say, what makes this work and what makes this fail, right? So if you are a medical team leader or a hospital system, and you have hired a wizard to come run ECMO for you, right? And this wizard comes up and says, I've got this magic thing. And if I touch your patient with this magic thing, their heart's going to keep going, even though it would otherwise stop. You can't understand how it works. It's just in this bag and don't look behind the curtain. It's fine. But I'm going to tell you when things are wrong. And I'm the only one who can interpret the will of this magic machine and tell you what it's going to do to your patient. And obviously that's not ECMO, but to some extent that actually is ECMO, right? If you're from the point of view of a non-perfusionist. So from that perspective, the problem set looks like, how do you work with an absolute expert in their field where you really cannot gain expertise in their area? You really have to trust them and you have to build this and interpret that. And then maybe let's poke at that and then we'll turn the problem on its head and say, hey, if you're that wizard or whatever, like how do you talk to the rest of the team? But what does that feel like to you when I say that? What's that bring up for you?
That is so funny. I was having a conversation earlier today where we were talking about medical transport of ECMO patients. And the person on the other line was very familiar with medical transport, but said, I have no idea what a perfusionist does. And I started laughing because you tell people that you're a cardiovascular perfusionist and they all shake their head and they all, have no idea what you do. So you're like an anesthesiologist. No, we're in the OR. That part's similar. How many perfusionists are there in the world? There's about 3,000 or 4,000 in the United States in total. Oh, that's it? Yeah. And as perfusionists in the hospital, even in hospitals that I worked in for over a decade, you would tell different people in the hospital that you're a perfusionist, and they would again shake their head and nod in agreement that, oh, yes, of course, you're a perfusionist. Nobody knows what you do. So they all, in their mind, make up what a perfusionist does, right? No, a perfusionist. Yeah, you are in the OR. You run the heart lung machine. Yes. That's the end. I don't need to know anymore. Because as a physician in the hospital, you say you're a physician in the hospital and everybody understands, oh, you're the leader of the team that's taking care of the patient. They may not know specifically your specialty, but they know that in an event, if they need a leader and they need the expert, they look to the senior physician in the room and they know that they have that person. When the perfusionist is in the room for ECMO, or the ECMO specialist, most of the time we have a very good relationship with everybody because nobody knows the machine and they don't want to because they may not see it again for a month. They don't want to try to drill in too far on it. They know the philosophy that supports the heart, supports the lungs, keeps blood moving. Got it. If anything happens other than that, this person will swoop in and fix what's broken. And the trust is intense between the team and the perfusionist or the specialist. Without that trust, you would spend the entire time you were in the ICU answering thousands of questions. And then 12 hours later, you would repeat them when you got a new care team. And then 12 hours later, you would repeat them again. And nobody in the ICU or the ED has time to sit down and answer 12,000 questions about what's currently going on with the patient because you're trying to keep the patient alive. So there's that trust factor that's inherent with perfusionists and ECMO specialists that we can't violate. If we violate that by putting somebody who doesn't know the answer at the bedside, when that catastrophe occurs, there will assuredly be a bad outcome.
So if we abstract slightly, we're asking the question, how does a ultra competent elite team graft on a deep knowledge specialist where there's basically no overlap? And we've talked about this before on the podcast as we think about the dilemma that high performing teams face, which you could sometimes call the buy versus build dilemma, right? A lot of teams go out and they have a mission and they have a job, and there's some new thing that either has to happen or can happen. And they face this dilemma of should they build that skill, which is take one of their own people who they've trained that knows their system that they know and teach that person that skill, or should they buy that skill, which is to say they take that skill and another person who didn't come up through the same pathway and bring them into the team. We see this a lot. We're seeing this all the time now with AI and drone technology or cyber or space domains where teams that otherwise had a very specific mission are now trying to think about how do we bring in an expert that does something that's so wildly different than what we do. And I think that trust component that you said is obviously a huge piece of it. And what you said at the end there, where if we ever get this wrong, it's going to cause a problem. And that's definitely right. And I think it's also going to cause a problem much downstream from them, right? Because that next group that shows up in that room, they're different ICU doctors, it's a different perfusionist, but they're going to carry sort of the battle scar of that prior conversation, even if none of the same human beings were in the room for this new generation of it. So
that is exactly right.
So when we think about trust as a building block, what else do you put on that list? What else do you do if and take either position you want, right? You're either the team who is bringing in an expert, or you're the expert who's going to the team with your wizard machine or whatever it is, right? And you're like, how do you bridge that gap?
Yeah. So the education portion is paramount, right? If nobody knows even the basics, then it's all a mystery.
Sure.
So you have to start demystifying what you can. And you do that general education. You do that through multiple patients. The more patients you have, you take away more mystery. You take away, we did this the same on the last patient. As the comfort builds with that patient type, then your ability to take on more critical patients or more risky patients, the comfort goes up, you take on more risk. The comfort goes up again, you take on more risk. And that is done through repetition. That is done through success with critical patients. And that is done through trust in that the equipment generally doesn't fail. And that is done through building trust by exposure to those teams. And unfortunately, the first patient's always the first patient. The trust level is expected to be high, will remain high until the critical event occurs, and then will either become higher or post bad outcome will be lower. And,
Sure.
and then you have mitigation opportunities too. Why did it happen? You start the root cause analysis of where the failure occurred. Was it patient? Was it system? Was it equipment? Was it specialist? Where did that happen and how do you resolve it? But that's always the problem with a new program is this equipment is only used on people with an expected mortality of 75% or greater. So your expectations are low going in the door. Once you put them on the equipment, they appear stable. And for the first time, maybe in 12 hours or 24 hours, they're pink and they're well perfused and they have a good saturation and their blood pressure is a meaningful number. And so your magic machine is exactly what it appears like. It's, oh, they're all better. And then you bring the family to the bedside who is seeing their loved one for the first time in maybe a long time, somewhat stable. And it's really important to impress upon them that there is no additional level of care that we have above this. This is the end. If you set expectations in oh, they look great. Now everybody expects a good outcome because they look great. Using just those words, oh, they look great. They look so much better, really sets a false tone for the family, the clinicians. They have to be reminded that the patient is still critically ill. They're very dependent on this device and the interaction of the device working. And it's up to the body now to recover. We have to wait for the body to recover because ECMO is a therapy. It is not a treatment.
Sure.
All we're doing is supporting the system long enough for repair, medications to work, or maybe surgical intervention or surgical correction of the problem if it's something that's what led them to ECMO. But that is how I see that interaction and that trust building occur over time. It's implied at first. As long as everything goes smoothly, it will gradually build, but it is very fragile. And that first critical event will show any chinks in the armor that exists with that trust.
I'm struck by the delicateness and finesse of this very powerful system, right? Like when it works wonderfully and it is the last line of therapy and can save people who are otherwise going down in flames, right? And I'm fortunate enough to have seen that happen. But it has to work so well. And the margin of safety, the band within which it can operate is so narrow in some cases. And, what we haven't really talked about here yet is how long this has to work that well for, right? Like you mentioned that this could be days, weeks, or even longer. And, the vigilance required, I think that's the right word, the vigilance required for a team to maintain something that they don't fully understand, that they can't necessarily fix themselves in a very tight window for long periods of time is a particularly unique and it's certainly a challenge that I personally would find very difficult, but I think a lot of teams struggle with that sort of discipline around it. So you mentioned that.
And it's great. It's a great analogy because we're used to dealing with ill patients. But when it comes to super stressful events, those are usually time limited. And then you go back to stable but ill. But those super high stress, if anything fails, we lose the battle events. And this is like this prolonged evolution of this. Everything's got to work. Everything's got to work. Everything's got to work. Any failure and we're in trouble. I've never heard anybody put it that way. And that is a super good example of what we're dealing with. That's a wonderful way of saying it.
Because you have both a threat and an opportunity there. And the opportunity is that it's more time together with the team. So now you're creating a sense of connection and a sense of rebuilding and an opportunity for people to trust each other more. And then at the same time, it's more opportunity, more surface area for things to break. And if we think about that sort of relationship, like, what do you do in that period of time? We've talked to teams before, for example, that have a real discipline in this space about training, about drilling, about mock codes, or this stuff that's come out of the Australian teams, the visually enhanced mental simulation, where the flat Maggie kind of work, where they use this as a teaching opportunity. There are other teams where that breeds complacency. And then when something breaks, the downfall is even that much harder. What do you see that works in that space when you send people out to that kind of world?
And we have very specific low occurrence, bad outcome events that we practice repetitively. And those are clot in the centrifugal drive unit. Those are accidental decannulations. Those are tubing or cannula displacement where the large tube that's in the vessel comes out. And if it's the arterial one that comes out, you're actually actively exsanguinating the patient into the atmosphere. Yeah, if it's the venous one that comes out, you're filling the patient up with the volume that's left in the circuit. And we practice these and we drill these and we test these and we do these on a basis that people are like, I've been doing this for 10 years. I've never had this happen. Great. I hope you do it for 10 more years and you never, ever see it happen.
Yeah.
We do a lot of ECMO. We get a lot of opportunity for bad things to happen. And if we don't practice these, when they do happen, you will have missed your only opportunity in your career to provide a viable outcome because you got complacent. It is, even in the simulation world, these events are stressful. They're traumatic. I've seen clinicians profusely sweating working through these. I've seen clinicians shed tears at the end of it with both good outcomes and bad outcomes. But that level of ownership leads to high levels of emotion post-event. And it's part of the care and the compassion, right? If they didn't care and they didn't have the compassion for what they were doing, it wouldn't bother them. So we do practice these low frequency bad outcome events on a regular basis with our team. And I think that's what every team has to do. The drawing blood from the circuit, yes, we practice that. We show competency for that. If you're at that low level of success being wonderful, if any of these bad events occur, the outcome won't be something that you want to talk about as a success. I can almost promise you.
Yeah.
And they do happen so infrequently. The complacency is, everybody gets complacent to where, oh, I've been doing this years and I've never seen it. That's great. That's wonderful. That means your system of checks and balances is in place. You're being diligent. You're keeping track of the situations. You're putting the fires out before they take off. When you get complacent, you're sure to see some of these rare events, and that then promotes more training, more competency. The old adage of good times produce weak men produce bad times produce strong. Same exact thing in this. It's very important. Most teams practice monthly, and your exposure to ECMO patients may limit that to quarterly. If you're doing a ton of these patients, you probably need to practice less because you're seeing them clinically and you're seeing them real time. If you're not seeing them real time, you need to increase the frequency of disaster events that you're preparing for. And you need to be comfortable telling people that they didn't meet the standard. If they're not meeting the standard, they don't get a pass. They don't get we'll do better next month. You have to be a little harsh in these evaluations.
Yeah. I just this week read Decker's Field Guide to Understanding Human Error. And I'd read a lot of his stuff before, but this is the first time I'd read that. And he talks in there a lot about everything from like the new view of safety leading into the safety two sort of idea of learning from normal work and the difference between work and done as work is imagined, all of which has a lot to do with these sort of systems when you're getting at a very complicated thing with, really complex, not actually just complicated, but a really complex system with a lot of interaction and nonlinear interactions and all sorts of stuff. But one of the things that was in that stuck with me is this concept that no one thing is responsible for an accident any more than one thing is responsible for safety. And I think what we're describing here is a very complex system that has a lot of surface area and time and space where things can go wrong and requires sort of a different approach to learning from the normal day in and day out process of it that empowers the team to learn more about ECMO and empowers the ECMO practitioner or the perfusionist to build better connections with the team, and that has this sort of ethos around the work that can downfield or downrange or whatever make a big difference when something does go wrong and all of a sudden there's blood spraying everywhere.
Yes. Having that dedicated team for ECMO where everybody's on the same mindset, the same resolution pathway does make solution and problem solving much more collegial and the chances of getting to a good outcome high. When you have these teams where only one person is familiar and knowledgeable about the technology, the trust factor has to be higher. The expertise of that person has to be higher. The ability to communicate the problem and the suspected solution has to be high. It has to be done quickly. And in rooms in chaos, and we've all been in them, when there's 20 leaders and the noise level is so high, you really don't understand the pathway to solution. If those occur in ECMO rooms, it's pure chaos. It is pure chaos. A quiet, functioning room has a chance of success. A disorganized cacophony of people talking has a very limited chance of success. I'm sure you've seen that a million times in your own practice. And we do very challenging things where we'll have to change an ECMO circuit on a patient that is failing, but it's failing gradually. We foresee that coming prior to a total failure. We'll change that with a new system, but that means we have to take the patient off of support for a period of time. We have to connect a new machine to them, and we have to do it in a sterile fashion. We may not be able to support the patient hemodynamically or from a respiratory point during that entire period we're off of support. And there has to be the trust that you know what you're doing. You're going to be able to do it in a time frame that it will maintain the patient's long-term goal. You don't want an anoxic event. You don't want a new infection. You don't want an exsanguination. You don't want shards of plastic getting forward. And when I was a young perfusionist, you would go into the room to do this, and people were screaming out the sats, the heart rate, the time. And I'm like, oh my goodness, I'm going as fast as I can. Telling me that the sats are 50, it won't make me go faster, but I don't know if I need to stop what I'm doing to listen to you, or if you're trying to tell me to hurry up. So as more trips around the sun, now when I would walk into a room, I'm like, hey guys, everybody's got the role. Do you have any questions? Go through the entire team. Doc's in charge. You're going to stand over here. You have volume. You have code meds drawn up. You have all this. During the event, I will let you know when I clamp the patient off of ECMO, and I will let you know when I put the patient back on ECMO support. Please don't speak during that time unless it is something that requires action from a team member, so that we know if you're talking, we have a response that's necessary. And once the room got quiet, the anxiety level comes down, people's roles are defined. And as the perfusionist, I would do that. Really not anything unique, but somebody had to do that. And everybody always felt like they were contributing to the success when actually they were just contributing to the noise that distracted the team from a successful transition. So I'm sure you have your own technique for doing that. As we get older, we all seem to find our methodology for doing that. But in a crisis, that's always seemed to work the best for me, is to quiet the room, focus the room, try to get everybody on the same mission.
Totally. I think we see that work really well with teams when they're able to put that into place ahead of time, when they're able to have that conversation ahead of time, be like, hey, and before we do this, here's our plan. And not just here's our plan, but here's our plan for communicating. Here's our plan for backups. Here's our plan for what the next thing is. Here's how we're going to think about risk, and here's how we're going to manage risk. And to the extent that we can dial that in and build a shared mental model for that, we're much better able to respond to whatever curveballs we get, versus if we're in the middle yelling, everybody be quiet, which very rarely you have to do, but most of the time that's already, you're behind the 8 ball there.
Time is so critical. If you waste 10 seconds trying to get the room to be quiet, you're 10 seconds further into a bad outcome. It's so important. Done well, a circuit exchange, I participated in them in under half a minute of time off of ECMO, from off of ECMO to back fully supported. With problems, they extend to 2 and 3 minutes quickly. And laying that on head times is huge. Having those emergency systems in place, knowing who's in charge, knowing what your role is, pre-planning is second to none.
You know, we talked about the discipline of bringing in a specialist into a team and about trust. And I think this is also part of the conversation around that, which is the getting the docking systems in place so that both parts of the team understand how they're supposed to interface and where and why. And then having the expertise to understand, even if you don't know what the other person's doing, their shared mental model, even just recognizing this is the boundaries, the left and right boundaries are the most critical period in time.
Yeah.
I was having a discussion the other day with an orthopedic trauma surgeon about what is a very common procedure in the emergency department, which is sedating a patient for a reduction. You put them under so that the orthopedic doctor or you or whoever can either splint a broken bone or reduce a joint or whatever it is. And we realized as we were having this conversation that as the emergency doctor, my mental model of this thing was that the most critical point in time was getting them to be sedated and then bringing them out of sedation, right? Because that's where the airway issues happen, or they aspirate on something, or their blood pressure, whatever it is. And in the orthopedic doctor's mind, the actual critical point of the whole thing was some moment where they're doing the reduction, and it's really some sub moment inside the reduction. And we ended this conversation looking at each other being like, wow, we actually did not know that about the other person's point of view about it. And to the extent that you can have that set of conversations, even if it's, look, I don't understand what you're doing, but when there's this giant orange light that comes on, I need you to know that's the most important thing for me. And when the orange light's off, then we can go back to being a normal person again. You don't have to know what the orange light does, but you have to understand that we're on the same page about it. And like that level of conversation is just critically important for these multidisciplinary, multi-professional teams to actually operate in these moments. And so often it just doesn't happen. There's not this pre-conversation about it.
And if you do take the time to have those conversations, so if you're in the bedside and things are quiet and you get the opportunity to say, if this ever happened, this is what we would do. This is what I need you to do. If I am stepped out of the room to look at an x-ray and blood spraying, I want you to take a clamp and put it right here. I want you to get my attention, whatever you need to do, but put a clamp right here. That changes their comfort level. Now they know in crises, I can do this to buy us 20 more seconds, or maybe they're buying us another minute. And if they buy us another minute, we have another minute to get a solution in place. And just having that 5-second conversation with a bedside person changes their comfort level the whole night or whole day. It changes their ability to react to an emergency, which is what we all want. We all want to be able to maintain this patient, maintain this circuit. And we do those things. Those are very low pressure, very easy to understand directions. And that's how we always start at the bedside. If something bad happens, I want you to do this. And then the next time you go, you know what? This is actually the emergency drive unit. So if you had to do that, the next thing we're going to do is we're going to put that in here, and we're going to be able to manually support the patient in case of a power failure, catastrophic failure of the console. Now their comfort level went up a little bit higher maintaining that patient, and their trust of you as the colleague went up. And those are the exact ways we start building what you did with the trauma surgeon and the orthopedic surgeon. You're now understanding that, he doesn't care when I say the sedation is going in. That is not thinking about the airway, not thinking about maintaining hemodynamics, thinking it's almost my turn to step in and treat the patient. And it lets you know that you better keep thinking about the airway because they are not thinking about it.
Sure.
So that relationship is stronger now because you know that this is mine. This is in my bucket solely. I need to maintain this. I don't need to worry about the reduction. I don't need to worry about that because that's really where they're focused, and they're going to perseverate on that specific detail throughout this whole event. And we have the same thing for us. I am desperately worried that when that system is not flowing, if I don't get it started fast enough, the clot will prevent me from starting again. Nobody else in the room is thinking about that. And I know nobody else is thinking about that. So if I lose track of what's important to me, nobody else will pick that up. Nobody's going to pick that piece up for me. And knowing that is important.
Yeah.
Knowing where you're stepping out of what you're maintaining and into their region. If I'm worried about whether the IV pump's working or not, I'm letting go of something that nobody else is worried about. And I'm trying to interject myself into something that 10 people are worried about because that's their area of expertise. And during these situations, you have to stay into the solution that's going to get to the good outcome, which is fixing the machine, fixing the problem with it, getting the patient back on ECMO, getting them back on support without a congealed circuit, without a system full of air, because you opened a central line and filled your entire system full of air. Staying focused on where you can contribute the best to a good outcome is important.
I love it. Thomas, thank you. Thank you so much for coming on the podcast and doing this. I want to give you a chance as we're wrapping up here to issue a challenge to folks, something that you want them to do differently on their next shift or their next rotation or their next time on a team like this. And to stall for you for a second and give you a chance to think about that, I'm going to do our normal disclaimer here, which is that our job here on the Emergency Mind podcast is to take the best of what everybody else has already learned about performing under pressure and bring it to you, whoever you are listening to this. Nothing that we do is medical advice, and neither myself nor any of my guests, rather, let me rephrase that, myself and my guests are only speaking on behalf of ourselves, not anybody that we work with or for. So with that in there, what do you want to issue a challenge to people for? What do you want them to do differently when they're done listening to this podcast?
My challenge would be for each person that enters the ECMO bed space to walk away from that bed space with more knowledge than they walked into about the ECMO system and what to do in one type of emergency. Just one. There's 1,000 different things can fail in that system. Walk away knowing how to take care of one of those, or how to participate, or what to expect.
Love it. And if folks want to learn more about what you all are doing at Integration Health, how can they find you?
So if you go to Integration Health with a Google search, look up our company, look up what we do, and then reach out to us. Or if you want to reach out to me directly, it's I'm@integration.health. Send me an email. Happy to talk about ECMO anytime you want to.
Amazing. Thank you so much for coming on the podcast.
Thank you. It's been fun. Have a nice day.